John's Foundation Leadership Council. Good afternoon. And the Foundation Leadership Council is a group of community leaders whose purpose is to support the strategies of St. John's Hospital and ultimately support the work of the Foundation's professional fundraising team. I've been a part of the Leadership Council for a few years now, and our goal is, to help Bev and her team at the Foundation drive the philanthropic engine for the hospital. It's used to fund a lot of the top priorities, special projects, and a lot of times just cover unexpected costs that come up from time to time that weren't necessarily in the budget. I'm also proud to say that today's esteemed presenter is also part of our Leadership Council. So I'll go ahead and turn it over to Michelle to tell us a little bit more about Dr. Thiele.
Well, thank you very much. This is good afternoon to everyone. My name is Michelle Martin Seelbach, and I'm honored to introduce Dr. Thiele, our speaker. Dr. Thiele is a Springfield clinic provider that specializes in comprehensive colon, rectal, endoscopic services, and adolescent and adult patients. This includes colon resections and other procedures on the large and small intestines, including those afflicted with Crohn's disease. In addition, a full gamut of anorectal surgical expertise is available, including hemorrhoid, fissure, and fistula treatment. Lower endoscopy and colonoscopy and flexible sigmoidoscopy is available both for a diagnostic and therapeutic vantage. Dr. Thiele is specially trained for Da Vinci robotics surgery as all aspects colorectal disease. Thank you.
Awesome. And then we'll pass it off to you, Dr. Thiele. I know you've mentioned you have some slides to share. I just made you a co-host so you can share your screen if you'd like, or you can speak, whatever you prefer. You're currently on mute now.
There, can everybody hear me? I was going to share my screen. I didn't want this to get technical like a lecture, but my wife has informed me that it's impossible for me to talk about this topic without being technical. So I was just going to run through some slides pretty quickly talking about colon cancer screening and treatment and include a few videos because show and tell was always my favorite subject. And Bev actually asked me to just give a little background about myself as well, and I got a couple slides on that. So I'm going to try to do this.
I can stop my share.
Okay.
Right now, and so you have the ability. There will be a green share. There you go. You're starting to share it.
Let's see. Does that work?
Yep.
Can everybody see that?
Looks good.
Okay. Just real quickly, from my background, I am from Blue Mound, Illinois, which is 1 square mile right in smack in the middle of the state. I grew up there. It was a great place to grow up, a small rural setting. In 1986, a recruiter from Springfield College named Bev Neisler came to Blue Mound and recruited me to Springfield College, which is how I came to live in Springfield. From there, it was off to U of I to finish my degree. Then medical school at Southern Illinois University, a year in Carbondale, and then back to Springfield again here. I did finish my degree here and then spent an additional 6 years in residency as a general surgery resident. After that, St. Louis was calling, and I finished up at Barnes-Jewish Hospital, Washington University for just a year there. And then back to Springfield with the Springfield Clinic, where I've been for 19 years. So colon cancer, a third leading cause of cancer in men and women. It's 9% of all newly diagnosed cancers in this country. Estimated 150,000 people will be afflicted this year with colon cancer. It's the third leading cancer killer in men and women. It accounts for 11% of all cancer deaths. Lifetime risk in this country is about 4%. And why I say this country is because it's much more prevalent in a westernized, a modern country like ours. Relatives, first degree relatives, and family history is important. But a lot of people who tell me, oh, I don't have a family history, why should I get screened? 80% to 90% of colon cancers are without a family history, so they're sporadic cancers. Although the overall death rate has been decreasing due to screening, the under 55 population, however, we've seen an increase in deaths per year, 1% per year over the past decade or so. And because of this, the American Cancer Society has actually recommended that we decrease standard screening age to 45 to see if we can combat that. Some of the risk factors, again, like I said, sporadic cancers account for the vast majority. But this particular condition, HMPCC, I'm going to touch on a little bit later. It's a genetic condition that we're testing more now for, and we're finding this is a relatively old slide. This is more than 20 years old, and this is actually a much bigger part of the population, and it's important to screen those patients because of their dramatic increase in risk. The general risk factors: urban areas over rural areas. Caucasians have a higher risk factor than the Mexican Indian population. A lot of alcohol intake is a big risk factor. The American high-fat, low-fiber diet. Smoking causes adenoma formation and some secondary risk. And then people who have had a cholecystectomy have a condition called steatorrhea, where they have fatty stools, and that puts them at a bit higher risk. So the polyp to cancer sequence, it seems inherent or intuitive now that we know that polyps cause cancer, but that wasn't always the case. There's been several people that have suggested that benign polyps in the colon eventually lead to cancer, but we didn't really know that specifically until the 50s when Jackman and Mayo described it. And there's some indirect evidence of this, as we can see that a lot of times we'll see residual adenomas in cancer specimens. And so we know that that progression is there. And also 10% of cancers show evidence of benign adenomas in continuity with invasive growth. And also there's a correlation of cancer risk with adenoma size. The bigger the polyp, the higher the risk. And that's part of our screening process as more intense in people with large polyps. And then there's a condition called familial adenomatous polyposis, or FAP. And those people will all get cancers if we don't treat them. And we know that this is a standard benign adenoma that what I would see on a screening colonoscopy. And this is what somebody with FAP looks like. So they have thousands of polyps in their colon, and because of just sheer number, they eventually go on to become cancers. And this is what a larger polyp would look like, a pedunculated stalk, and this is the head of the polyp up here. So this is a busy slide and basically describes the known genetic alterations that we see in this progression from normal colon through the stages of adenoma to cancer and subsequently to metastasis. And this isn't important. What's important is this takes 10 years. We've proven it. In the vast majority of patients, it's a 10-year process, and that's where the screening recommendations of every 10 years after a normal scope is based on that. So how do we screen for colorectal cancer? You know, in the past, it was standard stool samples. It was looking for blood. Today, that's an optical colonoscopy is what we mean by screening for the vast majority of patients. So in the average risk population, we start at age 50. And again, the American Cancer Society has made the recommendation that we decrease that age, but not all insurance carriers are recognizing that. Ultimately, they will, as societies like my society and other start to recommend it. And again, in the old days, a flex sig with a barium enema and then annual fecal occult blood testing. But in today's society, colonoscopy is the key. And follow-ups based on if you have polyps, how many were there, what were the size, and what's the question of residual polyps. So if you have a very large polyp and have to take it in what's called a piecemeal fashion in many, many pieces, then there's a higher risk. So in patients with a family history, if you have a primary relative like a sibling or a parent or a child, we typically start 10 years prior to their age of diagnosis or 40, whichever's younger. So if your mom had a colon cancer at 60, we start at 40. If she had a colon cancer at 38, we start at 28. And that's based on, again, that polyp to cancer sequence. The follow-up for its surveillance is based on what we find at that initial screening. So unless you have that genetic condition that we're suspicious for, or they're younger, the follow-up after the initial screen is identical to someone who doesn't have a family history. So how do we follow patients? So at your initial screen at age 50, if there's no polyps, it's 10 years. If you have fewer than 3 polyps and they're all small, less than a centimeter, you get 5. If you have more than 3 or any larger polyps, it's 3. High-grade dysplasia is very early cancer. We see those patients at a year. And if you have an invasive cancer, or the possibility of that inadequate resection, it's every 3 to 6 months. And family history is all based on the age of your family member at diagnosis. If they're older than 60, you get 10 years like everybody else. If they're younger, then we do it every 5 for the rest of your life. So what are the pros of colonoscopy? It's by far the best test to detect colon and rectal cancer and other diseases. In fact, flat polyps and areas of inflammation won't be detected on other screening tools because we're directly visualizing the lining of the colon. It's both diagnostic and therapeutic. If you have benign disease, benign polyps, we can remove them. If there's cancers there, even some early cancers, we can remove via the colonoscope. Anesthesia provides a painless procedure. In fact, the anesthetic agents have a lot of very nice side effects. You get a good sleep, it causes lots of euphoria, and it's painless. And now in this day and age, we blow the colon up and distend it with carbon dioxide, which is absorbed very quickly into the body. So your recovery is painless too. By the time you're awake, it's gone. And so that makes it very easy. As far as cons, they talk about real estate, everything. The most important things, the 3 most important things are location, location, location. In colonoscopy, the 3 downsides are the bowel prep, the bowel prep, and the bowel prep. However, split dose and low dose preps have improved this dramatically. I've performed over 19,000 colonoscopies, but I've only had one. I had it when I turned 52 years ago, and I can tell you that after having taken the prep, it's not that bad. Now, there is a risk for bleeding or perforation, bleeding issues if you remove a polyp is about 1 in 1,000, and it's very typically self-limited. Perforations were more common in the early days of colonoscopies. I've performed, again, almost 20,000 scopes and only 1 perforation in 20,000, and that was a patient with a diseased colon. So if for a standard screen, it's exceedingly rare. Cologuard's hot on the market right now. You've probably seen commercials about it. Don't worry about the prep, get a stool sample and send it in and we'll tell you if you have cancer or not. And what Cologuard is doing is looking for abnormal DNA in the stool. It's not looking for blood. So it's very specific for colon cancer. It's excellent at detecting colon cancer. 92% of colon cancers will be detected by Cologuard. Unfortunately, it misses more than 60% of even advanced benign polyps. So the intervals every 3 years, so it's a bit more frequent than colonoscopies, and it is much less expensive. But the problem is when you're seeing the colonoscopy detecting polyps at this range in Cologuard here, I recommend Cologuard for patients who, for whatever reason, can't undergo an optical colonoscopy. So maybe an elderly patient whose life expectancy is less than 5 years. In that patient, I don't care if they have benign polyps because that's not going to give them a problem. But I do want to know if they have a cancer right now, and Cologuard's great for that. But in a young patient, if you're going to miss this many polyps, it's not a good test. So I'd certainly recommend an optical colonoscopy. So this is just a real brief clip of what a colonoscopy looks like. This is specifically a dual channel colonoscope, so I can put 2 instruments in at the same time. And the reason I'm using this is because there's a very large polyp here I'm going to try to remove. This is a real-time test. We're visualizing it directly, and I'm sorry about the herky-jerkiness of the picture, if any of you get motion sick. But this polyp is coming into view here, and it's about a 3.5 centimeter polyp, so it's quite large. What I'm going to do is stabilize the polyp stalk with the grasping instrument, and then I'm going to work that loop, that wire lasso, over the surface of the polyp and get it around the base. And this snare actually is attached to a cautery machine. So once we apply electric current, it'll cut through the tissue just like a cheese cutter and remove that polyp. And you can see it's a very large, but a benign appearing polyp. It's soft. So eventually we work that onto the base of the polyp, and then we're going to close it tight. And then put a little cautery on it and hopefully cut right through that. And polyps like this are the polyps that are much higher risk for bleeding because they have a robust arterial supply in the base there. And then once it's been removed, we can actually use what's called a Roth net, which is like a butterfly net that we can grab that and pull it out in one piece. So there you go. That's after that's been removed. So that's why colonoscopies work, because a polyp that size is a high risk for cancer. As I mentioned, the earliest cancers are cancers within an otherwise benign polyp. And if this is your polyp, if you can imagine the polyp we just looked at, this layer right here is called the muscularis mucosa, and it goes up into the polyp. And if you have cancer cells on the surface that have invaded through that, then that's a very early cancer. And thankfully, those can oftentimes be treated with simple polypectomy, like you just witnessed. And if it's well differentiated, if there's no evidence of invasion into lymphatic vessels, and there's no what's called a mucinous component, which is a negative predictive factor, and if the margins are adequate, then you can treat it with a polypectomy alone. And we follow that up really frequently afterwards, every 3 to 6 months with colonoscopies to make sure there's been no regrowth. Ultimately, after that first year, if they're disease-free, then we can follow you up just like it was a benign polyp. So that's kind of one of the main reasons, or one of the big reasons why colonoscopies work. So colorectal cancer, it's become really complex over the last 25 years since I started doing this. The decisions that we make preoperatively are as important as those that we make intraoperatively and postoperatively. And there's been studies that have shown that a multidisciplinary approach with formal tumor board is the key to maximizing survival. So treating colorectal cancer in smaller communities doesn't have the same survival rate. It doesn't have the same low morbidity and mortality that we get in a place like St. John's Hospital, where we have a multidisciplinary approach. So I talked about this Lynch syndrome, this called hereditary non-polyposis colon cancer. And the key with the genetics is, you blame your parents, you try to help your kids. So genetically speaking, this was originally described by Warthen, who was a pathologist in 1918. And it's interesting that his seamstress was depressed because she said everybody in my family dies of cancer, and she was convinced she was going to. And ultimately, she did die of endometrial cancer. And Warthen actually did a family pedigree and discovered this condition, but it didn't gain any attention until Henry Lynch described it about 50 years later. And now we know that it's an autosomal dominant trait, so it's not carried on the sex-linked, it's the autosomes. Autosomal genes, and it's dominant, so that if you have it, there's a 50-50 chance you can pass it to your children. And why is that important? Well, when you look at HMPCC, there's a dramatic increase in a lot of different types of cancers. The mutations we see are what are called mismatch repair genes. Everybody watching this program has had cancer at some point in their life. It's just that your body repairs it at the cellular level. So when the DNA unzips and the cells divide, when they come back together, if the base pairs don't match up, that's called a mismatch. And so these genes are responsible for repairing that. And if you lack those, you're at a much higher risk for cancer, especially in tissues that are turning over rapidly, like the endometrium or the lining of the intestine. So testing for these genes historically was very expensive. It's not now. But from a screening standpoint, we actually look for a condition called microsatellite instability in a pathology report. So over 90% of patients that harbor this condition will have what's called microsatellite instability. And when I started my practice, we would never test for that. And in fact, to get the pathologist to test for it was a big deal. But again, with this multidisciplinary approach to the treatment of cancer that we're seeing at St. John's Hospital and Memorial Medical Center as well, now part of every pathologic analysis of any colon cancer in the city is microsatellite instability, which really has helped us to identify a lot of these patients earlier in life. So in patients with this condition, there's a much lower adenoma to carcinoma ratio, and there's an accelerated progression from benign polyps to cancer. As opposed to that 10-year interval we talked about earlier, their dwell time is as little as a year. And so a normal colonoscopy means a lot less to these patients because in a year or two, they could have a cancer and not just a benign polyp. So they're also at risk for what are called metachronous cancers and synchronous cancer. So synchronous cancers means you have two cancers in the colon at the same time. Metachronous means you get a colon cancer and years later you get another one. So, and also what we call extracolonic neoplasm. So you can see endometrial cancer in these patients, 60 to 70% of depending on the mutation. For colon cancers, 82% of patients will get colon cancer with this mutation by age 70. And the metachronous cancers, if you only remove part of the colon, they'll get a second cancer, would fit half of them, and will get a second cancer in 15 years. There's a lot of other ovarian cancer. While these numbers are not nearly as high, they're way higher than the normal population. So screening is really important for these patients. And with routine screening, like colonoscopies every 1 to 2 years, upper scopes every 2 to 3, we get urinary analysis every year and gynecologic exams. And then patients, after they're done with childbearing, we recommend prophylactic removal of the uterus and ovaries. And with routine screening, you can see the dramatic effect. So these are patients that are getting this aggressive surveillance. We're finding benign adenomas and early cancers as opposed to these patients, the majority of them being found in the stage 3 and 4 cancers. So really a huge benefit. So with sporadic colorectal cancers, there's a preoperative workup, there's operative approaches, and post-op management and surveillance. So by sporadic, I just mean it's not linked to any family or genetic situation. So obviously everybody gets medical clearance. Go talk to your doctor and make sure you can tolerate the operation, because surgery is the backbone of treatment for colon cancers. With laboratory studies, it's basic stuff, except for the CEA. CEA stands for carcinoembryonic antigen. It's a protein that's produced by colon cancer cells. And this is we get a baseline CEA pre-op, and then we follow that post-operatively to look for evidence of recurrence. Imaging studies, CAT scans are important to evaluate for metastatic disease, and also to stage the extent of more aggressive stage 4 disease that's spread outside the colon. And it estimates tumor burden if metastases are present. The last thing you want to do is open somebody up and find this massive metastatic cake of tumor. This is not a curable situation with surgery. It's not a curable situation with chemotherapy in the vast majority of cases, but chemotherapy is the one thing that's going to extend their life. And if you operate on this patient first, you've now delayed their chemotherapy. So those are things that have changed dramatically over the past 20 years. Colonoscopy, I rescope all my patients preoperatively because I want to verify the site of lesion and do my preoperative planning. Some patients, and I'll talk about rectal cancer in just a second, but if indeed the cancer isn't in the colon, if it's lower in the rectum, then some patients will get neoadjuvant or before surgery therapy. And also we have the ability to tattoo smaller lesions. A tiny cancer that's maybe just a few centimeters can be very difficult to feel in the colon. And so what I do is I use the same kind of ink you would use to tattoo, I love mom on your arm, and we tattoo the inside of the colon right where the lesion is. Those tattoos actually are permanent. So if you have a big polyp you want to remove and you want to look at that again in a year to know exactly where it was, you can just tattoo that area. So you get to go through the bowel prep again after your colonoscopy for your surgery. And stenting, just like we stent heart arteries, like those good guys over at Prairie, we can stent colon cancers as well. So if a patient is obstructed from a cancer, we can put a self-expanding stent in, open the cancer up, allow us to mechanically prep the bowel so that surgery is safer. And that's something that we do a fair amount here in town. So operative management, until part of the reason that I went to WashU is that Jim Fleshman, who was the chairman at the time, had the biggest experience of laparoscopic colon approaches or approaches to colon cancer surgery. When I finished my residency in 2001, nobody in Springfield was doing laparoscopic approaches. Now, almost everyone that treats colon cancer does at least some sort of minimally invasive approach, whether it's laparoscopic or robotic. The principles are the same. Take the arterial supply near its origin. We get wide margins on the colon, 10 centimeters if we can, and harvest lymph nodes for proper staging. So a standard laparoscopic approach looks like this: small incisions, long skinny instruments, and the surgeon is standing bedside, and then here's your assistant running the camera. So it takes a couple of people, and the instruments are rather crude. They have 2 degrees of motion, most of them. They open and close and they rotate. A robotic approach is different. The Da Vinci robot system is actually what's docked at the patient's side. There's 4 arms, and the surgeon has control over all of them, including the camera. The camera is on one of these arms. The surgeon and sometimes the assistant, if at St. John's Hospital, we have a dual console system like this, so I can have an assistant, and then there's an assistant at the bedside to change instruments out. But the surgeon sits very comfortably while the robot does the work. I'm going to show you, this is how we manipulate the robot, and this handle has 8 degrees of motion. So all of the instruments have the same degree of mobility that my own wrist does. I'm going to show you a couple of videos later about the difference between laparoscopic and robotic surgery and kind of some of the benefits. So in general, people, when I tell somebody they have a colon cancer, the first question is not, can you cure me of this problem? It's, do I need a bag on my side? That's almost always the first question. And with colon cancer, the answer is no. The vast majority of patients do not. Hospital stays, when I was first starting my practice, almost invariably was a week. Now with minimally invasive approaches, it can be as little as a day, but 3 days is about average. My nursing staff and my partners and I have been working hard on what's called an enhanced recovery protocol for colon surgery. It's a big hot topic in a lot of different areas of surgery. In the old days, and Chris will confirm all this, that everybody got a nasogastric tube. Everybody was on bed rest. Everybody had a catheter bladder for 4 or 5 days. We didn't feed you until you passed gas, and we kept you in the hospital until you were having, full bowel function and eating and drinking. Now, none of that's done. Nobody gets a nasogastric tube. We walk patients in the hall the same day of surgery, and some people go home before if they can eat, they can go home. And so we're seeing on average savings of 2 days in the hospital, which equates to probably $4 million of savings for the hospital. And patients are happier too. When you're home, you're happier. So postoperatively, routine office visits are the norm. Routine labs. We talked about that CEA, which is how we follow patients for recurrence. And then endoscopic evaluations, we do it at a year. And assuming that's normal, we do it every 3 to 5 years thereafter. So imaging studies, basic x-rays are kind of the norm. We don't do chest x-rays as often anymore as a standard screen. We follow that CEA level. And if it's rising, we do further imaging. And that is not just CT imaging, but also metabolic imaging. And I'll talk about that in just a second. So rectal cancer is the same for colon cancer. Everything is virtually the same. All the studies we do verify the site of the lesion, look at the remainder of the colon. The big thing with rectal cancer is, in addition to that, everybody gets a pelvic MRI scan to stage the primary cancer. And the reason rectal cancer is different is, so again, MRI scan is assessing all of the surrounding tissues, and it determines the need for potential surgery or treatment before surgery or neoadjuvant treatment. The reason rectal cancer and colon cancer is different is the rectum its location is predictable. It's fixed in the pelvis, and the bony pelvis protects it. The colon's a mobile organ. To hit it with radiation beams can be very difficult to predict where it's going to be. There is a much higher risk of local recurrence, and that can be huge morbidity for the patient. And also a wide, I talked about with colon cancer, there's that wide margin of resection, 10 centimeters. It's not possible in the pelvis in many cases because the bony pelvis prevents it, or your desire to hook a patient back together so they don't need a colostomy bag prevents getting that wide margin distally. So, avoiding that colostomy is important. And even with rectal cancer, 50 years ago, almost everyone with rectal cancer got a colostomy, and now less than 1% of my patients need a permanent colostomy. So we've really gotten better at that. So in the preoperative staging, the questions I have when I look at a rectal cancer: do I need to shrink it? Do I need to accept a closer margin, that distal margin, so I can hook them back together? And is the lesion a high risk for local recurrence? Is it a big lesion, or are there a lot of lymph nodes? And if the answer is yes to any of those, patients will get radiation prior to surgery. And that's kind of become the norm. Again, my experience at WashU, Ira Codner was the sort of godfather of colorectal surgery down there. And he was one of the first people to suggest radiation should be given prior to surgery, not after surgery. We used to radiate a lot of patients after surgery, but function was bad. And radiation kills cancer cells by forming what's called oxygen-free radicals. And so when it uses oxygen to kill cancer cells, it's going to do better if the blood supply is better. And so the blood supply to a cancer is much better prior to surgery than after. So some of the easiest way, or the least morbid way to treat a rectal cancer, if they're very early, is a transanal excision or a local excision. So the rectum, we have access to it via the anus. The colon lesions are too high, but through the rectum, we can directly go through the rectum and remove an early cancer if need be. And again, that's based on a lot of things. Is it mobile? Is it early? Larger cancers or cancers that are deeply invasive or have surrounding lymph nodes all need more major surgery. But on occasion, we do find these smaller lesions that we can treat with a transanal excision. These same approaches that I talked about with colon cancer are available for rectal cancer as well. And in fact, robotic surgery is a much better tool, or a bigger tool to use in the pelvis, because the pelvis is very confined. I don't find a big benefit to using the robot for a colon cancer operation, but laparoscopy certainly, but not a robotic operation. The distal margin is how much rectum do we have downstream from the tumor, so we can leave a little bit to hook a patient back together. We like to take that 2 centimeters if we can, but the big benefit, if the patient's been radiated, all I need is a grossly negative margin. So that can allow me to leave, the least little bit of rectum so I can hook a patient back together. So a comparison of laparoscopic versus robotic surgery. This is a laparoscopic operation, and you'll notice several things. The picture quality, not exactly the best in the world, but it's good. And you'll notice that the instruments, if you can imagine grabbing an instrument that's this long, that's 1.5 feet long, and pointing at something and using it to operate, any motions that you make are going to be exaggerated at the tip. And so there's a lot of tremor that any tremor you have is exaggerated, and it's just not nearly as precise. You can see the grasping instrument I'm using is it opens and closes and it rotates. And the cautery that I'm using, it doesn't do anything. It's a fixed instrument. And these are great to use. And what I'm doing here is I'm using the cautery just to incise the attachments to the colon. You'll see that once those are broken, using the cautery, I can bluntly sweep the colon away and bring it toward the midline, which is kind of what you do with this part of the colon. So you can see those attachments, once they're broken with the cautery, you can just sweep those away. But again, it's much less precise than the robot, but you do have some tactile feedback. When you touch tissues with any of these instruments, you're feeling, are they firm, are they soft? You can feel how much trauma you're creating by touching those tissues. With the robot, it's different. You don't have any tactile feedback, so you have to be much more precise. But this is a similar dissection. I think you can see that the picture is much better. You can see that I'm controlling everything. I'm controlling the camera. This is my assistant is using suction here. You can compare this instrument and how it moves to how the other ones move. Across the bottom here is my dashboard. It's telling me what I'm using. I'm going to put this instrument against the prostate here, and I'm going to freeze it in space. And now it will stay there for me. And then I'm using this instrument. But you'll notice the cautery here is a scissors, but when it comes down in the pelvis, you'll see it kind of goosenecks up, and I'm doing that with the console. And so this is an extension of my hand essentially, and you can see how there's virtually no extraneous movement. When my hand is still in space, it is still in space, and both of the instruments have cautery on them. And it's hard for you to appreciate being, not doing colon surgery all the time, but the view that you're getting here is amazing. And during an open operation, I would never see any of this. In fact, the vast majority of what you're going to see me do here, I would have done bluntly. And so I just saw this vessel and I sealed it, and I'm going to cut it with cautery so it doesn't bleed. Blood loss is dramatically lower with robotic surgery in many cases. So, and then to get low down the pelvis and see, there's some muscle fibers way back here that you're going to see here in a second. They're going to contract when I get close to them with the cautery. Those are the levator muscles, and that's basically the floor of the pelvis. And to see that visually is something that before robotic surgery you could never see. But dividing these tissues sharply with the cautery and coming across them in a bloodless plane is just much better for the patient. It also allows you to preserve a lot of the nerves that help maintain sexual function in men, and also bladder function in men and women. So you can see how you see those muscles contract down there. To be that low and be able to do this to stimulate those muscles is unheard of in an open operation. But as you come around, you'll see that I can actually reach around the corner with this instrument and do some dissection bluntly. But everything has to be very gentle, because again, I'm getting no feedback as to how hard I'm pushing up against these tissues. But it's just much more precise in the pelvis. And allows for much, and there's a little vessel you're going to see, and cauterize that to prevent bleeding. So once we've got that all mobilized, what I've done then is I've swapped out those cautery scissors for a stapling device. And that's what this is. This blue end is the cartridge. There's 6 rows of staples, and then an anvil with a blade on it that will cut in between. So if you look over at this part of the stapling device, you can see that's what the staple hits to crimp over. It looks just like a standard desk stapler. And what I'm going to do is come across, here's all these muscles down on the base of the pelvic floor. So we're all the way down to the pelvic floor. The stapling device is going to come across the rectum, and I'm finding a good place where I can close it without any tension and make sure that we don't have too much tissue within the stapling device. So I'm kind of test fitting, and I'm also, you can't see it here, but there's a tattoo where the cancer is. So I'm making sure that we're below the cancer, but I'm leaving some rectum downstream to hook the patient back together. So once I got a good spot, I'm going to clamp it down, and the robot then is going to clamp here, and you'll see it squeeze the tissues. And once it squeezes and gives me an indicator that it has closed all the way and it's safe to fire, it gives me a countdown to firing, and then the robot will fire everything for me. And as there's an anvil that progresses through the cartridge and deploys the staples and cuts them in between. And then when it's done, it's going to unclamp, and you'll see how the rectum is divided, and there's a staple line on either side. So here's your staple line sealing the proximal rectum, and down here is the staple line sealing the distal rectum. So with operative management, all the same factors apply. We want to keep the surrounding tissues intact. For patients that, even if I can hook a patient back together, if they've been radiated, or if I'm in the lower part of the rectum, those patients get a protective ileostomy. So I bring the small intestine out as an ostomy, and they keep that for about 2 to 3 months. And then we go back later and hook them back together if the connection has healed properly. The leak rate is way higher for a rectal cancer patient. So in those diverted patients, we clear the colon prior to takedown. I leave any ostomies in place if they need chemo, because it's just easier for them to tolerate that. And we evaluate the anastomosis with what's called a contrast study. We just put some radiopaque contrast up there and make sure it's watertight. So again, I talked about CEA to look for recurrent disease. An elevated CEA tends to get some sort of imaging study, because that can indicate recurrence. And in this day and age, and you may have, if you've had any family members with cancer, you'll know that PET scanning has become a big part of how we follow any type of a malignancy. So PET scanning is a radioactively labeled fructose molecule. So it's 2F18 fluoro-2-deoxy D-glucose positron emission topography, which is a good thing they abbreviate that as a PET scan. So we're taking advantage of the fact that cancer cells are more metabolically active, and they lack an enzyme called glucose 6-phosphatase. So this FDG labeled fructose molecule is brought into the cell, and because they lack this enzyme, it becomes trapped. And so as that radioactive tracer accumulates in these active cells, we can then use a special machine to detect that. So PET scanning, you can scan the entire body, and we typically combine it with a CAT scan so we can overlay the two images. PET images are very hazy and imprecise, but when you overlay a CAT scan, you can see exactly what's happening. So in this particular case, elevated CEA level, an indeterminate liver lesion is seen, and also a small lung nodule. And when you overlay that with your PET, you can see that's very metabolically active, indicating malignancy. And down here is a mesenteric nodule that isn't even visible on CT scan, but shows up as active on PET. Now, there's other things that can show up active on PET. Active infection is very metabolically active and can show up on PET. But in a case like this, when you have a dominant mass, that's something that is going to be a high degree suspicion for malignancy. Again, here's a situation where something's not even visible on CT, but you can see it. This is a stand-up sagittal view here on the right, where you can see it in the middle of the abdomen, and it's correlating with this lesion on PET. And it's also helpful for me with local regional things. So here's a case where you can barely see a little fullness in the rectum here. And this was after a transiently excised lesion that I did. And then PET scan shows that as obviously active. So that patient then went on to get salvage surgery. So it's great to determine whether a patient has a curable situation. If PET shows distant disease, then oftentimes you're not going to jump into surgery as your initial treatment. And it can prevent a morbid operation without any chance for cure. And it's also probably the best initial test to look at a rising CEA. You can see your true positives and true negatives are much better with PET scanning. So when you talk about asset allocation, definitely we want to be in the red here. We want our assets to be in screening and initial treatment, because this is way more expensive on this side. And that's why it's important that you get screened, because initial treatment, after you catch cancers earlier and you prevent cancers with removal of adenomas. So the take-home message is, again, get screened. It's the most important tool in prevention of colorectal cancer. Any individual that gets routine screening for colon cancer who is at average risk has a 70% reduction in your chances of dying from colon cancer in your lifetime. Surgical treatment can be minimally invasive, and there's a lot of options to enhance that recovery. And treatment can be achieved in the vast majority of cases without a permanent colostomy, even in relatively advanced disease. Genetic testing can identify high-risk patients, so talk to your doctor about that, especially if there's a family history in your cancer of not just colon cancer, but the other things that we talked about. And there's no question that a multidisciplinary approach with formal tumor board discussion amongst numerous specialties dramatically improves outcome for colorectal cancer. So that's all I got. Are there any questions?
Awesome. Well, thank you very much. We actually did get quite a few in the chat. So I'll read those to you right now, and I can share my screen so that way we have some more information. All right, let me find the chat. I know one of the questions was, is there an age that is too young to receive a colonoscopy?
No. Certainly patients with symptoms, and to give an unfortunate story, I just saw a patient a couple of weeks ago, 32 years old, and she was having some rectal bleeding, and it obviously concerned her enough that she mentioned it to her gynecologist. And as we talked, she was kind of minimizing the symptoms. And I said, you know what, even though it's stopped, if you start bleeding again in a month, we're not going to know. So we should probably do a colonoscopy. And unfortunately, she had rectal cancer. So a 32-year-old patient with rectal cancer, so yeah, too young, no. And certainly not even too old either. I just yesterday did a big operation on a 94-year-old with an advanced colon cancer. And her doctor told her when she was in her 80s not to get a colonoscopy because she was too old. So obviously that could have been avoided had she continued with screening colonoscopies. So again, life expectancy more than age. I have a lot of people in their, late 80s that are really healthy. And so if I think they're going to live 5 years, I do a colonoscopy. If I, and I have I have a patient in her 50s, but she's a brittle diabetic on kidney dialysis that has had a bilateral below knee amputations. Her morbid risk factors, she's not likely to live long enough to benefit from a colon cancer screening. So it's just a discussion to have with your doctor.
Sure, I understand. All right, one of the other question is, what are the symptoms of colon cancer? Are there many?
95% of the time, nothing. That's why we do screening colonoscopy. In fact, this 94-year-old I mentioned with a really advanced lesion, she had a little stomach upset that passed, and that's what brought her to the doctor that ended up, he examined her and could feel the mass in her abdomen. So with rectal cancer, bleeding, as I mentioned with this 32-year-old, can be a symptom. Now, granted, while most rectal cancers bleed to some degree, the vast majority of rectal bleeding is not rectal cancer, but it's important to rule that out. As colon cancers progress and obstruct the colon, bloating, early satiety, abdominal discomfort can be an issue. Or if somebody comes in and they're profoundly anemic. When colon cancers, as they progress, they tend to bleed small amounts, and over the course of many, many months, a patient's blood count might drop rather profusely. So fatigue, if somebody has a normal hemoglobin for a man is about 14, and I've had patients come in at 5, so that can be an issue as well.
Interesting. Thank you for that. Another question we had is, how long does it typically take you to perform a colonoscopy? Does it vary?
11 minutes. It's on average. I only know that because they track my time, so they know how to stack them in a day. So usually Wednesdays are a big day for me. I start at 6 a.m. at the clinic, and by 11, I'll walk out of there having done 10 colonoscopies.
Wow.
So it's quick, and the patients, again, recovery is, and I never knew until a couple of years ago when I had my colonoscopy if I was telling patients the truth or not, but the recovery is quick. You're in and out of there, and the total time spent in our facility is about 2 hours, but I left and stopped at McDonald's on the way home and felt like $1 million.
Awesome. Another question we had, are you typically at a higher rate to get colon cancer if you have current GI concerns such as Crohn's, IBS, that kind of stuff?
That's a great question. Inflammatory bowel disease, yes. Crohn's disease, ulcerative colitis, those are inflammatory conditions of the intestine, and that does put you to high risk. There's no question. After 20 years of active inflammation, like if somebody has active UC, ulcerative colitis, after 20 years, they have about a 10% chance of a colon cancer. And then it goes up about 1% per year after that. But a lot of patients now in this day and age with good medications, they don't have ongoing active inflammation in their colon, so the risk is lower. IBS or irritable bowel syndrome is a functional problem, and that doesn't increase your risk for cancer.
Good to know. All right, that's all we had in the chat. If anybody has any last minute ones, feel free to unmute yourself. Chris, do you have one? I just saw you.
Well, I had one little comment and a question. I don't know if Dr. Thiele's found this to be true, but when I started, which was before Dr. Thiele was a resident, so I'm really old, we would find a lot of our patients came in with later disease. One, because there wasn't so much information out there about screening, but people were just so embarrassed to talk about anything related to their bowel or their rectum if they were having like delay problems. Do you see that there's less of like a stigma with patients coming to their doctor and say, listen, I'm having a bowel problem, I'm having a rectal problem?
Yeah, I think there is. And I think a lot of it has been that some well-known people who've had colon cancer have come forth. I
Well,
don't know if
Farrah
any of you-
Fawcett had rectal cancer.
she
you
had
know.
anal cancer, actually, anal
Anal
squamous
cancer,
cancer.
yeah, true.
But I don't know if any of you are into movies and the superhero genre, but the actor who portrayed the Black Panther in one of the Marvel movies
Yeah.
died of colon cancer recently. And so here's a very visible young actor that a lot of young people look up to, not just as an African American in that kind of role, but just as a sort of a superhero figure. And he died of colon cancer. So there's been a lot of people, and that I think that's helped. When I was a young resident and you were a beginning nurse, standard screening colonoscopies were not routine. It's only been in the last, say, 15, 16 years that, when I first started, we were only screening about 30% of the patients who were eligible. We're doing much better now. Almost 2/3 of patients who are qualified for screening are getting it. And I think Cologuard and things like that have helped. What I don't like about Cologuard, again, is that some people see that as a true alternative to a colonoscopy, and it's just not, especially in the young population. I don't want to wait until a patient gets a cancer in their colon to know it. I want to find it when it's a benign adenoma and remove it. And so that's where Cologuard falls short. Now, in the next 20 years, could we have something that will definitively tell me if patients have benign polyps? Possibly, but the problem with that is that in the over 50 population, half the patients I screen, I find adenomas in. So, and most of them are benign and small and probably would never give you a problem. So I think it's easier and in the long run, cheaper to simply just screen patients based on their age and their risk factors.
Thank you. Anything else? We got time for a few more minutes.
Caitlin, I just wanted to thank Dr. Thiele for joining us today. This is just a really fascinating topic. And, I just found the information to be really, really interesting and really, to look out for, what could possibly be a sign of something that, like the young lady who dismissed it, but really it ended up being something significant. So thank you, Dr. Thiele, for sharing all your knowledge with us today.
My pleasure. And, I think we chose this topic simply because March is Colorectal Cancer Awareness Month. So if you're of that age that you need screening, get screened. Most in Springfield anyway, with the clinic, I don't know how SIU does it, but with our clinic, both the gastroenterology department and our department, if you are otherwise healthy and want to just schedule and not come in for an office consultation, if you don't have any specific questions, you can actually schedule over the phone. Just get your prep through the mail, you go, you get screened, and it's an easy thing to do. So it's it's a day of your life that could certainly save your life. So try to do it.
Doctor, are you open for new patients?
Absolutely, always. You
Wonderful.
can call the main clinic number 528-7541. Just simply ask for my office. Ask to talk to one of my nurses, and if they're available, they'll talk to you directly. But if not, you can leave a message on their voicemail. They'll get back to you within 24 hours. And you can just, like I said, I would say 90% of the screening colonoscopy that I do is people that either having done as many as I've done, a lot of people are repeat customers. I've already screened them in the past, but 90% of my screens, either new or pre-existing, are scheduled over the telephone now. So I find that, it's people don't want to like take off work to come here, sit in my waiting room for an hour, and then have me come in and say, so you need a screening colonoscopy? Great. You have any questions? Awesome. See you then. And then that's it. That's all that we do. So it makes way more sense to go ahead and just screen over the phone.
Thank you very much.
Sure.
I would also say too, Jim, you're absolutely right about the prep. You know, even 10 years ago, the prep was a lot worse than what it is today. And, you know, the first time I had to go through it, the prep was terrible, to the point where then it was time to go back. And I was fearful that I was going to have to go through all of that awful prep again. And I went to see Dr. Thiele that time, and it was seamless, and the prep was so much better. I felt really good afterwards, and all of that. And so you're absolutely right. I think that it's all getting much better with different things that are coming on the market, but the prep would have been something that I would have really hesitated to go back and get that screening because I just despised it so much. But Dr. Thiele assured me that it was much better and that it would go much more smoothly, and it absolutely did. So thank you for that.
Oh, yeah. And, you know, in the past, the preps were a full gallon of fluid and all of it tasted horrible. And even if it didn't, I mean, I love Pinot Grigio, but I don't think a gallon of it would be something I'd like to drink. So the lower volume preps are the norm. So half that volume, and then we split that into 2 separate doses. So split dose prepping helps get the prep down, but it also allows for a better prep, because in the old days, you would take the entire prep the night before, and then if your scope wasn't until say 10 a.m., you had 12 hours for your colon to fill back up with bile stain fluid from your liver. Well, now you take part of it the night before, and then the other dose is about 5 hours prior. So that, you know, continues to get your colon clean. So, and the results are much less, well, for lack of a better term, violent. I've had patients take the full gallon and then they take the newer preps and they're like, well, this just didn't work. I hardly want it all. And then I get in there and their colon is clean. So I think it never had to be as horrible as it was. We just thought that it did, I guess.
Wonderful. Oh, go ahead.
I just wanted to add one more comment. Also, I know Dr. Thiele was talking about robotic approaches, laparoscopic approaches, and the enhanced recovery after surgery. And I just noticed that patients have so much less pain than they did before. I don't know if he's upset too. Before, people would have just these huge abdominal incisions. Now, a lot of times they can just have a few lap sites. I had a woman the other day that had surgery and she was getting the enhanced recovery after surgery. She was on that protocol and she had already was getting the medicine scheduled, just the Norflex, the Toradol, and the Tylenol, and she really wasn't even having any pain and moving much better. So yeah, things have just really progressed, and people do a lot better, recover, go home, don't have as much pain.
We found that, and a lot of this, I mean, we basically took ideas that have been proven in other specialties. And my nurse, actually Dr. Wheatfeld worked with one of my nurses, and they together put this, the protocol together. And one of the biggest hurdles, honestly, was to get the seasoned nurses on the floor. We started at Memorial to get the seasoned nurses on the floor to get a patient up in the halls the same day of surgery. They just were really resistant to that. And then once we assured them, hey, this is very safe, it's the thing to do. A bed rest is the last thing you need after an operation. In fact, we also, we used to keep patients nothing by mouth for 12 hours prior to surgery. Now there's a specific product called Ensure Surgery, which is a clear product that has glucose, keeps their blood sugar up, and we give it 2 hours prior to surgery. So it allows them to stay hydrated. It keeps their blood sugars where they need to be, which is also kind of a bad thing. And the routine use of non-narcotic meds the narcotic use in our patients has been decreased by 60% in the post-op period. And so, and we've extrapolated that even to our open operations. Open surgery now, I routinely send colon operations in an open fashion. I send them home on day 2 routinely. So, I mean, and again, in the old days, that was a 7-day hospital stay typically. So the cost savings to the system is enormous. And infection rates are down, anastomotic leak rates are down. Everything has been improved. And infection rates, I mean, something as simple as keeping somebody's blood sugar in the normal range in the perioperative and intraoperative period, it helps to decrease infection rates. So it's been great. I've been real proud of our team, and St. John's actually is developing a system-wide enhanced recovery program for surgery. The problem with that is to get two surgeons to agree on something is difficult.
Well, the gynae onc started doing that too. I saw that.
I mean, it's because everybody, you know, I love it when some, you know, old surgeon like myself says, oh, this is great, I'll participate, but yeah, I'm not doing that. I'm gonna take that part out, and then they'll cross stuff out. You can't do that. Either you're on board for the protocol or you're not. You can't say, oh, well, that's great, but I'm not doing these three things, because it's the protocol as a whole that works. It's not any one individual thing. So I've been pretty proud of our team here, because at least at Memorial, where everybody, even though there's some things that like one or two of us disagree with, they're on board and they go ahead and still do the whole protocol. And we've noticed some good results.
Wonderful. Well, once again, thank you so much for your time. This was a very interesting topic. Definitely, obviously, if there's any questions, we can connect you to all the right people, and Dr. Thiele himself will have this slide and presentation recorded, and I'll send it out in a day or two. So if you have anybody else that you would like to share this information with, feel free. You'll see on your screen, this is my information, and then Bev Neisler in our office, our Chief Development Officer. If any questions, always feel free to reach out to us. We're always available. So thank you so much. Guys, enjoy the rest of your afternoon.
Excellent.
Thank you.
Take care, everybody.
Thanks,
Bye.
Caitlin.
Take care.
Thank you.
We do.